So for the last couple of weeks in the Friday Value videos, we've been talking about joint pain or joint inflammation or joint damage and how what you put in your mouth makes a difference. And you can protect your joints based on what you consume. I wanted to share a little bit this time about the risks and benefits of common treatments for arthritic joint pain, right? All of the things that we're recommended to do they work? And are there any risks? So you remember what causes the joint damage? We talked about it, right? All the excess arachidonic acid and the fat cells that produce those inflammatory cytokines. Well, now what we're going to look at is treatment. Pain medications for osteoarthritis. Do they work and are they safe? Now, you might happen to be a person who takes something and to you it works, and that's fine. And I'm not telling anybody not to take anything. I'm simply going to share what the data shows about these common treatments for OA. This study, there were 15 studies involving nearly 6,000 participants, and they were reviewed by the Cochrane organization using acetaminophen or paracetamol, which is another research term, for osteoarthritic pain. And what they found for knee pain specifically, they only reduced hip or knee pain, so they did look at hip as well, better than a placebo, which means something that can't possibly make a change in the body. It's an inert subject, by 4 points on a scale of 0 to 100. Now, if this was a scale of 0 to 10, it might be pretty impressive. But if your pain is at a 55, and after taking this, you're rating your pain at a 51, did it really make much of a difference, right? And the kicker is the physical function and stiffness were considered about the same between the medication and the inert subject, the placebo, which can't make a difference, right? And of course, there's lots of medicating risks with acetaminophen. It's currently in over 600 medications, both over-the-counter and prescriptions. So it's very easy to over-ingest it because you may not realize that it's in 2 or 3 or 4 different formulas that you're consuming for different reasons. You might be taking a cough syrup, a cough medication, a prescription med, and then an over-the-counter pain med, and bam, you've taken way more acetaminophen than you should be taking, right? What is it causing? Acute liver failure, liver transplant, even death. In this 10-year period, annual acetaminophen-related deaths amounted to 2 times those that were attributed to all other over-the-counter pain relievers combined. And over half the cases of acute liver failure in this 5-year period showed that toxicity from acetaminophen was the cause. And then looking at NSAIDs, let's not just pick on acetaminophen here. This was a meta-analysis looking at 23 studies of over almost 11,000 participants. And this is what they found for how effective NSAIDs were for knee pain. Now, I got to give you just a little background here for just a minute, because to me, this was fascinating. They looked at 268 randomized controlled trials, which means they were well done research trials. But 126 of them didn't have a placebo control group, because notice this says randomized, which means the computer chose who did what. Controlled doesn't always mean there's a placebo control, right? 115 of them included multi-site issues. It wasn't just the knee, and they were trying to tailor it down to just the knee. 4 of them didn't show a pain scale data, so you really couldn't tell if the pain was reported to be improved by the subject. So 23 were reviewed out of 268. So, okay, there's still 23 trials to look at. That's quite a good number. But when you look at the 23 trials, 16 of them were sponsored by the pharmaceutical industry, and we're looking at a pharmaceutical med here, right? And 3 others had the address of a pharmaceutical company as where the authors worked. So really, out of the 23 trials, only 4 of them would be considered to have a lower risk of bias, because it's considered there could be a bias going on if the company that's doing the study, is doing the study, right? Okay, on their own stuff. So 13 of the studies excluded participants from the study if they did not respond to NSAIDs. Little like stacking the deck in your favor, right? And the overall difference short-term found for the NSAIDs was only about 15% better than the placebo after 2 to 13 weeks. And only 1 trial looked at the long-term effect from 1 to 4 years, and they found there was no significant effect of NSAIDs compared with placebo. So this was their conclusion. It can reduce short-term pain in OA of the knee slightly better than placebo, and those are their words, not mine. But the current analysis doesn't support long-term use because of the serious adverse effects associated with NSAIDs. We can only recommend limited use. And a lot of people are taking these meds for years, chronic use, right? And these are the risks linked to lots of GI bleeding-related deaths, increased risk of serious cardiac issues, AFib. And when you look at the PubMed database for NSAID risks, there's over 22,000 studies. So this has been looked at a lot. Anything that's looked at this much says they're seeing this all over the place, and they're trying to figure out, okay, is this really happening? Yeah, it's really happening, right? And long-term use is associated with all these things, all kinds of GI issues, and not just GI issues, but kidney issues, cardiovascular issues. And it even will inhibit muscle growth. So if you're trying to get stronger, this study showed that it inhibited muscle growth, and this was a study looking at just quadriceps. Who's to say it's not happening in other muscle groups as well, right? Those using resistance training to maximize muscle growth or strength should avoid an excessive intake. Really? They weren't over ingesting it. So yeah, it's really important that we know these things so that we can make informed decisions, right? Informed decisions can give us better outcomes. All right. Thanks for listening.